Hi everyone, this is Tim, your Block 3 lecture instructor, and today's voiceover PowerPoint is going to be on management of patients with urinary disorders, primarily UTIs, kidney stones, and bladder cancer. The last couple slides are ostomies, which allows the urine to still be able to exit the body, but not necessarily through the urethra. It's pretty fast and straightforward, so let me know if you have any questions. So UTIs, they can be classified in two different ways. We actually have a lower urinary tract, which is the bladder and the structures below the bladder. And then they also have an upper urinary tract, which is the kidneys and the ureters. UTIs can also be classified as uncomplicated or complicated. Complicated is going to be recurrent. It's also going to be sometimes hospital acquired. Usually has a primary diagnosis, so if you have patients with urological abnormalities, pregnancy, immunosuppression, diabetes, or obstructions, those tend to cause the UTIs to be recurrent, and those are the ones that are actually considered complicated. An uncomplicated UTI are usually community acquired, and they're common in young women and not usually recurrent. So urinary tract infections, again, the most common reason is usually due to healthcare, hospital acquired. You'll find that when you're doing your clinicals that there's a lot of initiatives within the clinical setting because between Medicare and JCO and any other sort of entity that oversees the hospitals, they know that a lot of UTIs are coming from patients who are in the hospital and that are getting some sort of catheterization. So these initiatives are to help bring those rates down. Common sites of the acquired infection are usually lower UTIs, which is cystitis, prostatitis, and urethritis. It could also potentially be upper UTI, which is polynephritis. I had a patient this last weekend. She was in her early 40s, and it started off with a UTI. She didn't necessarily get the care that she needed and get the medication she needed to be able to get rid of the UTI, and eventually, over a process of 2 to 3 weeks, it turned into polynephritis, which means that it's a UTI that spread to her kidneys. If she would have waited a couple more days, she probably would have ended up going into septic shock just because of the fact that it was getting that bad, and it hadn't really quite reached her bloodstream, but it was on its way. Factors contributing to the UTI, it could be a bacterial invasion of the urinary tract. It could be urethrovesical reflux or uretrovesical reflux, and I'll show you some pictures on them. It could also be uropathogenic bacteria, and the fact that women actually have shorter urethras, it has a shorter distance for the bacteria to travel, so women are usually the most likely gender to get the UTI. So, question I have for you as you do your reading and go through this PowerPoint, what are some of the other risk factors for patients or even people getting UTIs? So other contributing factors, again, we mentioned the gender. Females tend to get them more than males do. Patients who are diabetics tend to get frequent UTIs. Pregnancies. There's also neurological disorders. Sometimes there are neurological disorders that don't allow your patients to either empty their bladder completely, or there's actually urine retention and that they're not able to go at all, and that will tend to cause the infection. The altered states caused by incomplete emptying of the bladder, I mentioned that. Decreased natural host defenses, such as immunosuppression, so they're trying to fight off everything and something's going to give, and UTIs tend to be the winner. Inability or failure to empty the bladder completely, inflammation or abrasion of the urethral mucosa. I had a patient this last weekend that was trying to pass a 6-millimeter kidney stone, and they literally had to go up and get it. Because of that, they go through your urethra into your bladder, to the ureters, and then to the kidney itself. And because of that, it actually caused some trauma and abrasion to the urethral mucosa, which was not uncommon, and it was kind of expected. But because of that, they have a greater risk of getting some sort of UTI because of the bacteria. Instrumentation of the urinary tract, such as catheterization, cystoscopic procedures. Again, that's what the gentleman had done, and he has a greater risk. Other contributing factors are obstructed urinary flow caused by congenital abnormalities, urethral strictures, contracture of the bladder neck, bladder tumors, kidney stones in the ureters or kidneys, which basically means that they're blocking the ability for the urine to pass from the kidney through the ureter to the bladder. Once it actually backs up, the bacteria tends to grow, and that's what causes UTI. And we also have compression of the ureters themselves. So again, anything that's stopping the flow from happening will cause a UTI. So here are the pictures of the Uretherovesical and the Uretherovesical reflux. So basically it means that you either empty the bladder and it doesn't empty completely, and urine does actually kind of backflow into the bladder, and again this urine sitting there will cause bacteria to grow, and that's what causes the UTI. So, of course, you can't do anything without ADPI. The nursing process, we have got assessment. Things you're going to look for, you're going to look for pain, burning upon urination, frequency, nocturia, incontinence, and hematuria. From my experience as a nurse, I've seen more patients with the burning and the pain on urination and the frequency. Your body's trying to create homeostasis, so it's got a bacterial problem, and it's trying to get rid of it by actually trying to flush it out through urination. And your body doesn't know that that's not going to work, but it tries to do it anyways. So the pain and the burning is from the bacterial infection, and then the frequency is to be able to flush your body out. Let's see here, about half are asymptomatic. So again, my patient that I had this last weekend with the polynephritis, she probably did have a UTI for about a week or so, not realizing that she had one. And then by the time she started getting the signs and symptoms, it might have been a little bit too late and traveled further up above the bladder. Association of symptoms with sexual intercourse, contraceptive practices, and personal hygiene. From what I've been told, women who tend to get a lot of UTIs are getting them from their partners, because it's the partner that wasn't necessarily as clean as they should have been that gave them the UTI. And also personal hygiene. You get elderly patients who are cleaning themselves as well as they possibly can, but sometimes that's not necessarily enough, or they're not doing a great job. And that's where the gerontological considerations come into play. Other assessments is going to be the urine, the urinalysis, and urine cultures. Again, you're going to be able to take a urine sample, send it down to the lab, find out what type of bacteria is actually growing. Once they determine that, then your doctor can actually put them on the right antibiotic. So that's for the other diagnostic tests. So you've got the urinalysis, the urine cultures. I think that's pretty much about it. So as far as nursing diagnosis, we've got acute pain related to infection. We've got deficient knowledge about factors predisposing patient to infection and reoccurrence. We've got deficient knowledge about detection and prevention of reoccurrence. We've also got deficient knowledge about pharmacological therapy. So a lot of things I want you to think about. Deficient knowledge, factors predisposing patient to infection and reoccurrence. So I've told the story many times before. Elderly patients who are either incontinent or not able to hold their bladder until they actually go to the bathroom, or aren't able to, I call it piddling, but they're not able to completely hold their bladder enough that they still dribble. These patients will either wear some sort of pad or wear some sort of brief to keep themselves as dry as possible. That's the good thing. The bad thing, though, is that if they don't know that they're wet, or if they're not able to actually clean themselves as often as they should, or as fast as they should, or don't clean themselves as well as they should, that bacteria is going to grow, causing them recurrent UTIs. The older patients get, the less likely they are able to notice the symptoms of UTI. that's what causes the UTI to get worse and either turn into more polynephritis or it becomes septic. It's too late by the time they realize that they actually have a UTI. Some of those patients that actually continue having recurrent UTIs will be put on a maintenance antibiotic like Bactrim. This is a pretty small dose. This is allowing them to continue living their life the way that they are going to live with the incontinence or the dribbling, but it keeps them from actually having the UTIs or it prevents them from getting worse. And that's for the detection and the prevention of the reoccurrence. So, some people, they don't understand that the pain and the burning and the frequency is a symptom of a UTI, and they either ignore it or they're not necessarily getting the help that they need, knowing that it's not going to go away. So that's what we need to start teaching our patients. Pharmacological therapy, we still have patients who are prescribed antibiotics that stop taking them the moment that they start feeling better. So a lot of that is more education on, taking the right antibiotic and taking it until it's completely gone. And that, if symptoms come back, you need to be put on another one or a stronger one or another round of it. So there's a lot of knowledge deficit based on UTIs, and as common as they are, and as much as we think, well, it's a pretty easy fix, not every patient is understanding what they need to do and how to prevent them. Collaborative problems and potential complications. So again, I mentioned sepsis, which is basically a UTI that went to the bloodstream. We've got acute kidney injury, and we also have chronic kidney injury. The UTI can get so bad that it actually causes significant damage to the kidney itself. And so not only do you have to teach your patients about the UTI, what the symptoms are, and how to prevent them or what to do when they do get them, we also need to teach them about the sepsis and the fact that if they don't get the help they need or don't finish the antibiotics or get rid of it, it could turn into potentially a bigger problem, such as the kidney injury and the kidney disease, and then they actually could lose them. So I don't necessarily believe in scaring patients, but I also think that if they understand that the complexity of what is going on and what they need to do to take care of it, then it just makes things a little bit easier for them. All right, so let's see here. Planning. Major goals may include relief of pain and discomfort, increased knowledge of preventative measures and treatment modalities, and the absence of complications. So again, you're going to control the pain and discomfort. You're going to provide antibiotics, pain management. You're definitely going to put them on some sort of fluid to be able to flush out the kidneys. Increased knowledge of preventative measures, telling them how they actually got them, how they can get them, what they can do to prevent them from actually happening. And then again, the end goal is really to be absence of infection. So pretty easy. We talked about the intervention, so relieving the pain, medication is prescribed such as antibiotics, application of heat to the perineum to relieve pain and spasms. I believe that could probably work. I'm not saying that it won't, but I think that the heat is probably going to help relax. And some patients do get spasms from urinary tract infections. There are actually antispasmodics that you can give patients to help them relax and be a little more pain-free. Increased fluid intake, so not only are you going to put them on some sort of maintenance fluids, but you're also going to have them drink as much water as they possibly can. Not only are we dehydrated because we live in one of the hottest and sunniest states in the country, but we don't drink enough, and so we need our patients to not only drink enough to keep them hydrated, but drink more in order to actually help flush out their system. Avoidance of the urinary tract irritants such as coffee, tea, citrus, spices, cola, and alcohol. These things will actually concentrate the urine, which will actually make the urine stronger, which will actually irritate the urethra. So frequent voiding, just to be able to for them to continuously empty their bladder, and then also patient education. We've got urine incontinence, affects more than 25 million adults in the United States, underdiagnosed and unreported. I think this is probably more of a an embarrassment thing than anything else. No one wants to believe that they're incontinent. They don't want other people to realize they're incontinent. It's whether it's an age thing and people don't want to look old, or the fact that they are starting to lose their bodily, functions. So that's why they underdiagnose it and underreport it. Affects women and men alike, and then symptoms of many possible disorders. So urinary incontinence is not just because you woke up one day and you can't seem to hold your urine. It's a lot of times it's a symptom of other problems, and usually it's a either a neurological issue or it's actually a urinary renal problem. There's different types of urinary incontinence. One of them is stress. A lot of times, the patients will either because of stress be again I call it dribbling, but either will dribble or they'll actually become completely incontinent. I think this is more of movement, and I've taken when you move patients in bed and you try to move them around and stuff, a lot of times they're just not able to hold it. The urge. I've had patients that have to go faster than they can get up out of bed to be able to make it. Functional, there's a nerve at the base of the bladder that tells you whether or not you have to urinate or not. If that's not necessarily working correctly, your patients will either retain until it's too late and then they go, or a lot of times, between the bladder sphincter and the ureters and the urethra itself, functionally is not working correctly and it just doesn't hold. They also have mixed incontinence, which is more of the urine and the bowels. And again, that could be either a neurological issue, whether it be nerve or cognitive level, or the inability to actually hold it itself. Patient education. So urinary incontinence is not inevitable and is treatable. I didn't realize that until I talked to a wound nurse that I have at the hospital that also does a lot in urinary incontinence. And she said that you can actually retrain your body to know when to go, or at least keep it on a schedule, and it will go at certain times. I do that for bowels. I just didn't realize that for urinary tracts. But very interesting is if you keep them on a schedule, go every hour on the hour, then it will eventually, it's more muscle memory than anything else. Management does take time, so it doesn't actually happen overnight. Education verbally and in written. Some people learn based on verbal cues, and some people actually do better based on pictures. Some people actually do better with writing. Developing using avoiding a log or diary. Again, this will kind of keep them on some sort of track to be able to get their body trained. Behavioral interventions. Again, it's that old saying that well, not really an old saying, but people, some people just can't go when other people are actually watching. And that's a behavioral, psychological issue. So a lot of times if people really just sit on the toilet and just relax and contemplate life a little bit, a lot of times it will actually happen. Medication education related to pharmacological therapy. Again, finishing all their antibiotics, making sure they have the right antibiotic for the right bacterial infection, and then also strategies for promoting continence. So again, you're really trying to retrain the body to go at a certain time every day, and making sure that's completely emptied, making sure that they're performing the right hygiene, and then making sure that they have the right medication for the right problem, and promoting continence, and that is not just something that you have to live with. Next, we have urinary retention, the inability of the bladder to empty completely. Residual urine. So basically, I had a patient this last weekend that broke his hip and he had surgery, and it was hard for him to urinate in bed using a urinal, and he was able to go to the bathroom in the urinal, but he wasn't able to completely empty. That urine that stays there will eventually grow bacteria and they'll get a UTI, which is essentially what he did. Causes include adults 60 years or older and may have 50 to 100 mLs of residual urine remaining in the bladder after voiding. Postoperative spasms, diabetes, prostate enlargement, urethral pathology, trauma, pregnancy, and neurological disorders may cause urinary retention. For my gentleman who is 80 some odd years old, he did have about, I'd probably say anywhere from 100 to 200 mLs left in his bladder after he had went. This was due to his surgery and the fact that the anesthetic kind of slows everything down to a point where his sphincter wouldn't relax for him to be able to go. He also was old, and he also had not necessarily prostate cancer, but he had some, some enlargements, some prostatic complications or problems. And also sometimes medications will do the same thing. Again, anesthetic is what it did for him. So it'll take a couple days for it to completely get out of his system, and then he probably will go back to normal as far as urinating. Urolithiasis and nephrolithiasis. Again, these are kidney stones that are in the urinary tract and essentially get stuck. Causes may be unknown. I have actually talked to people from different countries with different cultural backgrounds, and I have passed stones myself, and they have told me that it was based on my diet. Some people told me that mixing certain foods together will cause them, and some people have told me drinking too much dairy or consuming too much dairy will cause them too. So who knows? The pain for me was based on more where the location of the stone was lodged. For me, I don't really feel it so much in the kidney, and I don't really feel it until it's more in the lower ureter. The ureters are not the same diameter from the kidney to the bladder. They are a little windy, and sometimes they're actually narrowing in certain spots, and that's where my pain usually comes from. So it depends on the location and for the obstruction and the infection. I definitely have pain. I can't physically see the hematuria, but I've had urinalysis done, and they've actually told me that I've had, traces of blood, and it's because of the fact that these stones are not smooth; they're very jaggedy and sharp, and they pretty much scratch going from one, point A to point B, and that's where the blood comes from. Diagnosis is either radiography, blood chemistries, and stone analysis. I've never really strained my urine. I know that they they go from my bladder to to the end point, and I know when they're gone. Never actually had them analyzed, but they don't really cause me any problems either. Let's see here, potential sites of the urinary caliculi. So again, they're really starting in the kidneys. They can go from the kidneys to ureters, from the ureters to the bladder, and then out. So again, you can actually have them get stuck anywhere, whether there's narrowing or if the stone is actually too large. And that's one of the reasons why the patient that I had this last weekend, it was a 6 millimeter stone, and they knew that he would never pass it, so they went to go get it. They went up there and pulverized it into different pieces, and then they actually pulled it out. They just knew that'd be easier for him. Methods of treating the kidney stone. So here's where they actually go in and they actually get it. For him, it was actually stuck in a ureter. So the scope that you see here, it went through the urethra into the bladder, and then from the bladder to the ureter where they went and got it. They also could do something called lithotripsy, which is basically shock waves that will help pulverize the stones wherever they may be, and then allows you to pass them. I think lithotripsy is usually more for patients who have several stones that they know are going to pass, as opposed to just one. According to the CT scan, I actually have about 3 more left in my kidney, and one day they will pass. It's just a matter of when. I've had 2 so far my entire life, and we knew that there was 5, so it was just a matter of 3 left, and when will they come? They also can do it this way. Basically, you're going to do a scope and a needle where they actually go in through the back to the kidney, and they go into the kidney itself and basically pull out the kidney stone. This is very painful, but the other way, going through your urethra and your bladder and your ureters, is also very painful. So you got to kind of pick and choose which is more the easiest way to get the stones. Plus, if they go this way and it's painful, at least they went and got the stone and pulled it out, as opposed to it going from the kidneys and getting stuck somewhere, and then you have to go get it anyways. Patient education, so there's signs and symptoms to report. For my patient who had the scope to go get the kidney stone, I had to tell him what to expect. One, every time he urinated, it was going to be very, I think it looked more brandy wine than anything else because it's very dark and very bloody. It's because of the fact of the scope. And I had to tell him that's what's going to happen until he urinates enough and flushes out his system enough that eventually it will get less and less until it stops and becomes clear yellow again. I also talk about the pain. I can control some pain, but I can't control soreness. His penis is going to be sore for a couple days just based on the scope and having to go get it. But that will subside after a while. Let's see here. You're also going to, let's see here, follow up with care. My patient, I told him, and I don't think he will, but I had to instruct him, go see the urologist that did the scope. Go follow up with him in about a week or so. So one, make sure that things are okay, make sure that there's no sort of bacterial infection growing, make sure that, that everything is the way it's working the way it's supposed to. He's had these before, so I'm not quite sure if he would have done the follow-up care or not. They're also going to monitor the urine as far as pH, making sure that you have a good balance. Measures to prevent recurrent stones. Again, drinking lots of fluids, keeping yourself hydrated. These things will actually help dilate everything, whether it be your ureters, whether it, the more dehydrated you are, the more constricted things get. So you want to teach your patients to drink plenty of fluids, good hygiene, and again, as far as whether or not it's diet related, couldn't tell you. We talked about fluid intake, we talked about dietary education, and medication education is needed. So my patient did go home and Bactrim. He was on it for about a week, and it was just to prevent a type of UTI that would follow this scope. All right, so we also got urinary trauma. We've got your renal trauma, which can be caused by motor vehicle accidents, sports injuries, and falls. We've got bladder trauma, which is pelvic fractures, multiple traumas, or blow to the lower abdomen. And we've got urethral traumas, which is blunt trauma to lower abdomen and pelvis. Signs and symptoms, it's the classic triad, which is blood visible at the meatus, inability to void, and the distended bladder, which makes sense because if you need to pee and you can't, and your meatus is bloody, then most likely you've had trauma and everything is constricted. Trauma management. So medical management is going to control the hemorrhage, control the pain and infection, monitor for oliguria, monitor for shock, and signs and symptoms of acute peritonitis. Surgical management is going to be a suprapubic catheter or surgical repair. I've had patients who have had suprapubic catheters before, and it's usually going from the bladder through the abdominal wall and actually into a pouch. Nursing management is going to assess frequently. You know, make sure that what is going in is actually consistently coming out. So you're going to do very strict eyes and nose. You're going to instruct your patient on incisional care and adequate fluid intake to make sure that things keep continuously moving and flushing out. And then changes to report such as fever, hematuria, and flank pain. Flank pain is a pretty good sign that you've got some sort of kidney problem, especially with UTIs. It's gone from the ureter or the urethra to the bladder, ureters to the kidneys, and then the kidneys start to hurt. All right, so now we're on to urinary tract cancers, bladder cancer, kidney cancer, renal, ureters, and other structures such as the prostate. So you can really get cancer anywhere within the renal system. Cancer of the bladder is more common after the age of 55. It's the leading cause of death, and smoke increases your risk by 50%. Signs and symptoms is visible painless hematuria. Pelvic or back pain may indicate metastasis, the spreading of cancer. And the diagnosis is going to be ureteroscopy, exploratory urography, CT MRI, or ultrasonography. I actually have a friend who has a friend who had prostate cancer a couple years ago, and they removed his prostate, and the last couple of months he actually started having some bleeding when he urinated. Couldn't find out that even though they got the prostate based on the cancer, there must have been either some sort of cancer must have come back, but it also has metastasized to the actual bladder, and now he's got bladder cancer. But the symptom was the hematuria, and if it wasn't for that, he would not have gotten help because he didn't really have so much as far as pain, but as far as the blood in his urine. So bladder cancer management, medical management depends on the grade and the stage of the tumor, so they can do chemotherapy and radiation. Surgical management is going to be a transurethral resection or fulguration. I've dealt mostly with TURPs in the hospital, but basically it's a transurethral urinary transurethral removal of the prostate. We call it a TURP. And basically, you put patients on 3-way catheters and basically flush out that system until it actually pushes all the blood clots, and then they go back to home. Let's see here. Other surgical management is bacillocomentigarin, which is BCG treatment. We also have cystectomy and urinary diversion. The urinary diversion is the last couple slides, basically going from kidneys to ureters to bladder, and then the bladder will empty out through some sort of diversion. Nursing management of bladder cancer, so immediate post-op, monitor urine volume hourly for several reasons. One, you're going to make sure that what goes in is actually coming out. You're going to make sure that it's actually that what is going in, if it does not come out, it's got to go somewhere. And based on bladder cancer, they removed it. So it's got to go either internally, or maybe it's actually not producing at all. Provide stoma and skin care, which I'll show you some pictures of. Test urine and care for the ostomy. Encourage fluids and relieve the anxiety. You after having bladder cancer and having surgery to remove it, or having some sort of diversion, you now are noticing a hole that you didn't have before. So it's quite frightening, and there's a lot of anxiety because of the fact that you now have a different way of urinating. It's just almost like having a colostomy. There's now a hole where your bowel movements come out of, and it's kind of foreign to people, and how do they take care of it, and can they, and what do other people think, and what happens if it breaks, and all that other stuff. So you have to try to encourage your patients to provide them as much information as you possibly can, make them feel more comfortable, try to give them the empathy that they need, especially at that time. Patient education about self-care and managing the ostomy itself. Again, there's going to be a lot of anxiety, a lot of education based on what to do after they leave you and how to take care of that ostomy. And it just takes time and practice. All right, so urinary diversions, reasons, bladder cancer or other pelvic malignancies. I had a patient a couple of years ago, or actually a couple of weeks ago, that she was 86, 87 years old, and she actually had bladder cancer. They removed it, and basically they just rerouted the ureters into a ostomy, that was right at the abdomen, and she had lived with it for the last 5, 6, 7 years, and she just got used to it. So other reasons could be birth defects, trauma, strictures, neurogenic bladder, chronic infection, or intractable cystitis, used as a last resort for incontinence. I doubt that they would actually create a hole for bacteria to grow into, or another hole that needs good hygiene that probably won't get it just based on incontinence. So. They have cutaneous urinary diversions, which is ileoconduit, cutaneous uretherostomy, vesectomy, and nephrostomy. Continent urinary diversions such as the Indiana pouch, the Koch pouch, and the urethrosigmoidostomy. And I think these are, yes, so here's the pictures. So here's your cutaneous urinary diversions. So a conventional ileoconduit, the surgeon transplants the ureters to an isolated section of the terminal ileum, bringing one end to the abdominal wall. The ureter may also be planted into the transverse sigmoid colon or proximal jejunum. So basically, at this point, the ureters are being put together, and they actually empty into the intestines themselves. The cutaneous urostomy, the surgeon brings the detached ureter through the abdominal wall and attaches it to an opening in the skin. We have a vasectomy. which is the surgeon sutures the bladders to the abdominal wall and creates an opening through the abdominal wall, bladder walls for the urinary drainage. So the difference between a cutaneous urostomy and a vacostomy is that the cutaneous one actually comes from the ureter to the abdominal wall, and that could be anywhere from kidney line to like belly button, whereas the vascostomy is more of the hole is where the bladder is. The kidneys or the ureters come down and they attach the two, and then it actually comes right below the belly button. We have a nephrostomy, which is basically a surgeon puts in a drain directly from the kidney through the wall of the flank, and it drains that way. The Indiana pouch, the surgeon introduces the ureters into a segment of ileum and cecum. Urine is drained periodically by inserting a catheter into the stoma and pulling it out. A continent ilio-urinary diversion, or a Koch pouch, the surgeon transplants the ureters to an isolated segment of the small bowel, ascending colon or ileocolonic segment, and develops an effective continence mechanisms or valve. The urine is drained by inserting a catheter into the stoma. We have a male pouch. For male patients, the Koch pouch can be modified by attaching one end of the pouch to the urethra. And a ureterosigmoidostomy, the surgeon introduces the ureters into the sigmoid colon, therefore allowing the urine to flow through the colon and out of the rectum. And nursing diagnoses for pre-op, we have anxiety, imbalanced nutrition, and deficient knowledge. So again, you want to be able to teach your patients as much as you possibly can, and try to give them as much support as you possibly can to lower their anxiety. Postoperatively, we have risk for impaired skin integrity because of the stoma and because of the actual stickiness of the pouch itself. Adhering to the skin, it causes some skin irritation. We've got acute pain because we've literally cut a hole into you. We've got disturbed body image because these patients now have a pouch, whereas they didn't have one before. Potential for sexual dysfunction. Based on the problem and where it was and what nerves they actually have to irritate, will cause some sexual dysfunction. I think personally that initially trying to get over the fact that you have a pouch and that you have to urinate through this pouch and everything is kind of anatomically different than you've always been. I'm not quite sure if sexual function is really highest on your Maslow hierarchy. I think that once you get used to it, then eventually you will start to kind of get that want and that feeling back. But I think post-operatively, it's not necessarily top on your list. And then deficient knowledge. Again, why do they have it? Where do they have it? Where do they put it? Where's the pouch? How do you change the pouch? Those are a lot of things that your patients are going to have to know and learn how to deal with. And that's the end of the slides. So let me know if you have any questions. I know it was pretty fast, but I wanted to kind of touch base on the UTIs, the kidney stones, and the pouches and stuff. So if you have any questions, let me know, and I'll see you in class.